Good morning and welcome to your Robert J. Dole VA Veterans Town Hall meeting on this October 16th. My name is Gene Kimball, and I am the Deputy Public Affairs Officer here at the Dole VA, and I'm going to be your moderator for today's Town Hall. We're going to provide updates today on VA programs and services, followed by fielding your questions, but let's review some housekeeping notes first. Next slide, please. Please be aware that today's session is being recorded so others may view it at their convenience. If you have any questions at any point during our briefing, we encourage you to submit it via the chat window at your earliest opportunity. Also, at the end of our presentation, guests can unmute their mics to ask questions. When asking questions or making comments, please refrain from sharing personal information during the session, whether it be your personal information or that of a comrade or a friend. We do want you to be aware that the link to this town hall has been shared publicly, meaning that anyone could be logged in and watching us. Next slide, please. Mr. Michael Payne, Medical Center Director, joined the Dole VA back in July of last year. Since then, he has devoted himself to furthering the mission of providing world-class care to the veterans we serve here at the Dole VA. He's here this morning to address a few hot topics with you. Sir?
Okay, good morning, Mr. Kimball, and good morning, everyone, and welcome to our Dole VA Medical Center Town Hall. So I have several updates that I would like to share this morning, and I'll try to be as brief as possible. First one is, thank you again for joining us. As we've recently closed out our federal fiscal year for 2024, I want you all to know how proud I am to serve with such an excellent group of staff here at the Dole VA, who continue to provide such outstanding care and service to you, our nation's veterans. Our facility has done and continues to do a remarkable job, and it's reflected not only in the quality ratings and the veterans' trust scores, but in messages which I receive from you, our veterans, their families, caregivers, and survivors. These messages come to me through handwritten letters, speak to the director program, and in conversations with you as I round our facility and as I meet you out in our communities. I do my best to communicate those messages back to our staff as quickly as possible, as it helps me and encourages others to remember that every day we will remain ever vigilant to ensure that you, our nation's veterans, receive the highest quality care that you've earned and deserve. Next slide, please. So many of you likely have heard about our Centers for Medicare and Medicaid Services, known as CMS Annual Overall Hospital Quality Star Ratings, which were announced publicly a short time ago. I am pleased to report that for the second year in a row, the Robert J. Dole VA Medical Center has earned a 5-star rating. This places us in the top 8.2% of hospitals nationwide out of more than 4,600 hospitals surveyed. To clarify, we are one of 381 5-star facilities throughout the country. To be recognized in this way is a remarkable achievement, and it speaks volumes about the dedication, hard work, and commitment each of our staff members bring to the medical center and to our veterans each and every day. This recognition is not just a reflection of our high standards, but also of how the VA hospitals as a whole are setting a benchmark in the healthcare system. Nationally, 58% of VA hospitals receive 4 or 5 stars in this year's CMS ratings, compared to only 40% of non-VA hospitals. And for the Hospital Consumer Assessment of Healthcare Provider and Systems, known as HCHPS, Patient Satisfaction Surveys, we are once again outperforming non-VA hospitals with 79% of VA facilities receiving top ratings in patient experience. These figures highlight the exceptional care that we provide to our veterans, and it serves as a reminder to all of our staff of what they do each and every day and how it's viewed as exceptional by our veterans. Next slide, please. What makes this achievement even more significant is the trust that we built with you, our veterans. Nationwide, veteran trust in VA outpatient care has received and reached an all-time high of 92%. Here at the Dole VA, our trust score stands even higher at 93.4%. This is not just a number. It's a reflection of the confidence that you have in us to deliver the high-quality care that you've earned and deserve. Next slide, please. We have made meaningful improvements this year, particularly in patient experience. The surveys are showing that the Dole VA is providing a cleaner, quieter, and more responsive environment than ever before. Communication between nurses and patients have improved, and our staff's overall responsiveness has increased. We've also saw a decrease in readmission rates for conditions like heart attacks, pneumonia, and COPD. And our dedication to safety is evident. The intensive care unit recently celebrated an entire year without a hospital-acquired infection, a milestone that showcases our commitment to patient safety and quality of care. As you can see, the Dole VA has and continues to strive to provide quality care and veteran satisfaction at the highest levels. The 5-star ratings that we received is a direct result of our staff's commitment to excellence. We believe we make a difference in the lives of our veterans each day, and this achievement is a shared victory. We will continue to raise the bar and provide world-class, timely care as you've earned and deserve as our nation's heroes. Next slide, please. As I mentioned at the beginning of my comments, I receive a number of communications from veterans and their family members and caregivers each day. For me, these communications serve a very important purpose. It gives me the opportunity to hear your joys and concerns and provides us the opportunity to make changes in a timely and more efficient manner throughout our healthcare system. This Veterans Town Hall is one method of providing and receiving communication, but I realize some of you would prefer to communicate in a more private manner. We provide that opportunity to our Speak to the Director program. For those of you who visit our physical facilities, whether it be here at our main campus in Wichita or one of our CBOCs, we've installed Speak to the Director boxes in locations where veterans can take one of the pamphlets, fill it out, and either drop it back into the box or mail it back to the facility. For those who might not come to one of our facilities, we've made an online option for you as well. Simply go to the Dole VA's website, select the Contact Us link in the left column on the home page, scroll to the Speak to the Director section where we provided a fillable PDF document. Once that document has been filled out, simply click on the Submit or Send button, and the document will be sent directly to me. These messages are ready and read by me, and I share the information to the appropriate staff members when actions may be required for follow-up. Oftentimes, these messages are praises of our staff members, including our providers. When we receive these messages, we do our very best to communicate them with our team as many as possible and as soon as possible. I encourage any of you to communicate with me as often as you possibly can, as this is how we will continue to elevate our quality of care and improve your satisfaction with healthcare delivery throughout our system. Next slide, please. For those of you who joined us during our last Veterans Town Hall back in August, you heard us discuss our journey to becoming a more highly reliable organization, one that strives for a safer environment that's focused on reducing errors and preventing veteran harm. As we continue that journey, which is a never-ending journey, we want our veterans to realize it is a journey taken throughout the VA, from the National Program Office to our local VISN offices and each of our facilities. Not long ago, Dr. Patricia Hall, our VISN 15 Network Director, and myself signed a safety culture commitment document. This document lists 8 domains to which I and the rest of our executive leadership team have committed to our facility, our staff, and our veterans. We commit to 1, providing executive leadership support for more staff to attend safety forums, to supporting a robust RCA, or root cause analysis program, to being more aware and mitigating risks to our veterans' safety, to fully implementing National Center for Patient Safety team training and team training refresher courses, to supporting all staff to speak up with safety concerns to further increase psychological safety, and to embodying the principles of a just and fair culture, focusing on the system and not the error, to supporting standardization of process and equipment wherever possible, and to the completion of a proactive risk assessment, also known as a healthcare failure mode and effects analysis, or HFEMA. Next slide, please. We do this to improve the psychological safety for our employees and also the psychological safety for our veterans, their family members, caregivers. It provides an environment where everyone feels comfortable and confident in speaking up without fear of retaliation, and it enhances our ability to attaining zero preventable harm, at which we strive for every hour of every day. The graphs pictured here indicate that we have consistently improved in categories related to psychological safety in the past 4 years. That is no easy feat. However, there is always room for improvement. I feel strongly that communication is a key component in making these improvements, and I encourage anyone and everyone to take the opportunity to communicate joys and concerns as often as possible. Again, thank you all for joining us this morning for this town hall. Please know that it is our mission to provide you the world-class, high-quality care that you've earned and deserve. I'll turn it back to Mr. Kimball. Thank you.
Thank you, Mr. Payne. We are so glad you're here with us in Wichita at the Dole VA. Next slide, please. Dole VA has improved technology at the facility in order to offer our veterans the latest in treatment options. Dr. Donald Vasquez, Associate Chief of Staff for Surgery, has joined us this morning to provide an update on our robotic surgery program. Dr. Vasquez.
Morning, everybody. Hope you can hear me.
Yes, sir.
All right, we'll take the next slide. So I hate to start conversation with we were fortunate enough to be positioned here at Robert J. Dole when the administration decided that it was time to bring in a robotic system. And we did this, by the way, in the middle of COVID. Robert J. Dole has this system now. It's called the Da Vinci Xi, which is an upgrade from the former S. And this year, you can see there, our team completed 125 robotic surgeries. 111 of those were general surgery, 13 thoracic surgeries, and 1 urology procedure. The urology procedure was just amazing because it's what's called a bladder hitch. You read about that in textbooks, but you don't often get to see one. So it wouldn't be surprising to go a career without having seen but 1 or 2 of these. I saw that for the first time here and done robotically. That's normally an open procedure, but it was done here when a ureteral carcinoma, cancer of the ureter, the tube that goes from the kidney down to the bladder, was resected by our robotic urologist. So pretty special thing to have happen here, pretty special to be able to tell about it. And that's what we're capable of doing here. So we're going to talk about this a little bit more. And you can see a picture of the robot there. We'll have some more pictures to show you. So I'll take the next slide if you have it. So surgical robotics has been coming into the horizon probably since we had laparoscopic surgery. And what this is it's still laparoscopic surgery because it's called robotic assisted laparoscopic surgery, RAL. It's minimally invasive surgery, but it's supported by robot technology. And the robot itself really doesn't do anything of it by itself at all. It augments what the surgeon does, and it also dampens what the surgeon does, especially when it comes to tremor. And I'll explain that here in a little bit. You'll see what I'm talking about. But you've all held something in your hand and, where you're concentrating and you're trying to be exact about something. Well, that's when that tremor shows up. It just does. And the robot dampens that out so that it doesn't show up at the end where the instrument goes. So there's some players that you can see there, Da Vinci, Senhance. There's other robotic companies that are working hard to develop their versions of robots. In the orthopedic world, there's Mako and several others. Da Vinci itself has come up with what's called the Ion robotic platform, which we'll be able to have here in short order. So I'll take the next slide. So the Da Vinci is currently one of the most advanced versions of Intuitive, although the Da Vinci 5 is already making its way into certain areas, certain big high volume centers already have the Da Vinci 5. And the difference there is that with the Da Vinci 5, you can actually feel, for example, the stretching of a rubber band. With the Da Vinci Xi, you don't feel anything on your hands. It's all visual feedback. So you have to know what your tissue is capable of undergoing when you're dealing with it, because if you grab tissue inside the body and you just pull on it, the robot's extremely capable of just pulling that tissue apart. So that feedback of seeing what you're doing and limiting what your hands are doing based on what you're seeing for surgeons is a new sphere of existence, if you will. That's probably the reason why you don't see a whole lot of surgeons that have been in significant practice for time take up robotics, because you have to learn this weird thing about you have to look at it and make sure that you, by your visual assessment, that the tensile strength is not being overcome. Typically, surgeons feel everything with their hands. They're not into sticking a couple instruments in somebody, not being able to feel. Even with laparoscopy, you feel something. Well, with the robot, you don't feel anything. You don't get what you're feeling at the console is not representative of what's happening inside the body, and the feedback system is what you see. So that's what's interesting about it. But it does provide a high level of precision, flexibility, control in minimally invasive surgery. And we use it for the complex stuff that we used to do open. Every one of these, urology, gynecology, colorectal general surgeries, those are abdominal surgeries involving large incisions. And now we're able to do that with small incisions. We're also talking about cardiothoracic surgeries. They're doing some heart surgeries this way. Certainly, we've been able to do lung resections here, as I already showed. That's another thing to be proud of. I don't believe that there are that many intermediate facilities within the VA system, and I think there's about 11, if I'm not correct, if I'm not mistaken. And I'm not sure how many of them have the robotic platform going on in their system. So pretty proud of what we have in case that doesn't come across. So we're able to do here lung surgeries, lung resections for cancers, but the medicine team, the specialty care team, very robust program identifying lung cancers here, lung screenings and identifying lung cancers. Well, we're able to take them to definitive care, and definitive care with minimally invasive surgery using the robot here because of the Da Vinci Xi rather. Next slide, please. And here we go, right here. This is the old way of doing it. There's your surgery for lung cancer. You can see that it takes a big incision for the surgeon to be able to get in there underneath the skin, the muscles that are there, which are not small, latissimus dorsi and all the rest of those, and then to spread the ribs to be able to stick hands inside the chest to be able to resect the lung. Yeah, exactly. And sometimes you go from a lobe to entire pneumonectomy. And so that's how it's done. It says medical management at the top, but that's not correct. That's surgical management you're looking at. But this is from a talk that I picked up on the internet. So that gives you an idea. That hurts like the dickens. That causes a lot of pain, especially when you're talking back here with the muscles of the back. You can see there that the spine is in the midline there. It gets very close, very tender for a patient. Go to the next slide. And here is a similar surgery being done with the robot. You can see that there's 4 small incisions there. The 2 of them are over here close together on the right side, but there's 4 incisions there, and you can see the camera, what it's showing up there. The visualization is better than when you do it laparoscopic, a lot more detail. You can zoom in to within an inch of what you're seeing. Also, I'm going to have a comparison with laparoscopic tools here so you can see, because when you're doing laparoscopy normally, somebody's holding the camera for you. The robot is not managing the camera. So you're having to tell somebody, zoom in on here because I want to see this, or hold it still, or don't tremble, don't knock out your tremor. So that's number 1. And number 2, over on the right, you can see that the surgeon is actually quite comfortable sitting at the console away from the patient. And ergonomically, it's a marked improvement over having to stand at the bedside of the patient, which I'll show here in a minute as well. The system you see on the right is the Da Vinci S. That's the predecessor to the Xi. So that's the old system. Next slide. So it provides precision, provides accuracy, and actually some element of 3D visualization. It's binocular vision, to be exact. And the instruments mimic hand movements. I have a picture showing that a little bit. And hopefully reduces a little bit of human error in delicate procedures because it allows that kind of a precision. They say precision within 1 millimeter accuracy. You can see there that we've sat people here every once in a while, sat them at the console. There's some exercises that you can do for practice. especially for like residents. And you can see how easy it is to rotate those controls. It's actually quite an improvement over even open surgery, which is the standard, the gold standard. Next slide. And here you see open surgery. You can see the surgeon that's in the middle there. Look how hunched over the position is there. And that's how that works, whether it's in the abdomen, whether it's in the chest, and they end up with neck pain and back pain and having to stand. So, varicose veins in the legs and all of that business. Back, and, obviously sometimes also actually resulting in back surgery. My attending when I was a resident had to have back surgery after a 30-year career doing surgery. Next slide. So just to make sure we understand, minimally invasive includes both laparoscopic and robotic. They both lead to smaller incisions, which should translate to reduced blood loss, should translate to less pain and quicker recovery. It allows surgeons to work in small, operate in confined areas. The Da Vinci, however, gives you more control, and I think we'll show that here in a second. You do have shorter hospital stays. We're able to send bilateral inguinal hernias home the day of surgery. Gallbladders go home the day of surgery. Appendix operations go home the day of surgery, assuming there's not anything else going on. For example, a bad ruptured appendix with lots of abdominal sepsis, that kind of a thing. Reduced recovery time and fewer post-op complications. Next slide. And here you have laparoscopy on the left-hand side. This is normal laparoscopy with the small incisions, no robot. And you can see that they're holding sticks. You can see the arms are crossed there in the middle. So probably a little bit of sword fighting happens here and there. If the surgeon has to reach over across the one holding the camera with the right hand, you can see that there's opportunities to bump that arm, and the camera bumps and jiggles. And the person there on the left has to hold that camera so the surgeon can see, but stay out of the surgeon's way. And then the surgeon, all he gets to do is rotate at the knob. I'll show you that here, a close-up of that here in a second. And all his instruments do, as you can see on the screen, just open and close. That's all they do. And maybe rotate, but that's it. Over on the right, you can see the surgeons have none of that. There's none of that because the camera is operated by the robot. Everything's coordinated by the brain inside the robot, the computer brain inside the robot. And it's all guided by what the surgeon's doing over here. The surgeon can manipulate the camera from over here. They can manipulate all four instruments from where they're sitting. Next slide. So you get enhanced surgeon control and you get the ergonomics, obviously. You're going to end up with less surgeon fatigue, and I can attest that for you because I do hernias here as well with the rest of the general surgeons. And it is just, it's just night and day between having to stand at bedside, do an open hernia, inguinal hernia procedure, versus sitting in the console and what you can see inside the console, and actually look around inside the abdomen as well and do an abdominal exploration through the robot and the laparoscopic approach there. Next slide. Okay, here's the difference in tools, and hopefully this comes across, but over on the left, you see the laparoscopic tools, open and close, that's it. Pair of pliers, pair of tweezers, and they rotate. See the black knobs toward the handle? So basically a pair of scissors, they work like scissors. They open, they close, they grab stuff by opening and closing, and maybe they rotate. That's it. However, over on the right-hand side, you see the robotic control. And mostly the right lower quadrant picture there, that is what the tools over there on the left wish they could do. Bend like that. See all the angles, the degrees of freedom it can bend? And so that mimics the motion of the hand, as you can see in the upper photograph. And that's also, basically, you're looking almost like a gimbal here, if you know what a gimbal is. You see all the degrees of freedom between the controls of the robot, how it can spin, not just at the hand, but at the wrist. And basically, whatever the hand does, it gets mimicked with that instrument that you see over on the right. All those pulleys that you see there on the instrument, you can see the little wires making the going around the wheels, which activate the tips and the wrist motion. So you have basically, it actually can spin more than what your wrist can, because your wrist can go almost 360 degrees, not quite. The robot does 720 degrees. Next slide. So we talked about this, faster recovery time, shorter hospital stays. We have reports here of patients going home, and even though we write them for maybe a day or two of pain meds, taking no pain medication, not even Tylenol, after bilateral groin hernias. That's huge. That is just huge. Back in the old days, if we did a bilateral, back in the old days, we just recently, actually, within the last few months, we've inverted the ratio between open inguinal hernia surgeries and robotic inguinal hernia surgeries, because we did mostly opens here before we got the robot. Then the robot came in, and now they've flipped. The vast majority of them that we do here are robotic, and you can see that the patients here, even though, you know, veterans are complex patients, a lot of them have pain from what they did in the service. They're being treated for pain. Now, those are the people coming back reporting, I didn't take any pain medication after bilateral groin hernias. That's huge. Lower risk of infection obviously accrues to minimally invasive techniques. They get back to daily activities. They get back to normal quality of life. And most of them come back reporting faster recovery times with the laparoscopic approach, and definitely the robotic one. Next slide. Surgeon benefits, obviously, I think we've shown that they decrease surgical time for some complex cases. In the end, we hope that the having not to put patients in the hospital, having to avoid a hospital stay, a hospital readmission, lowers costs overall. There's a big upfront cost for the robot and its instruments. They're not cheap, but the way the robotic education goes from intuitive, their approach is to have you get good, then get fast. Then the third thing that they focus on is getting lean. And you see some of that here. You know, instruments don't get opened willy-nilly. Everything gets, we looked at, do we really need to open a suction device? Do we really need to open that? And that's what goes on actually inside the robotic room when these cases are going on, especially the multiple quadrant ones. A inguinal hernia is a single quadrant. You're just down in the left quadrant or a right lower quadrant. Something like a colon resection goes in between quadrants, so it becomes a more complex surgery. I hope that makes sense. And when it's kind of fun, you know, because I think prior to now, the VA has had a certain reputation around town. But now when you come around saying, yeah, we're doing robotic surgery, we're doing robotic lung resections, robotic urologic surgeries, and looking to add robotic gynecology, it gets people's attention. And furthermore, the residents that come through here, they go and they tell what they've experienced here. They get to sit at the robot. They don't often get to sit at the robot and learn like they do here. And so we get good word of mouth from the residents of the experience that they have here from the surgery, and the robot is a large part of that. And like you saw the two consoles, that's where safety comes in, because you have the surgeon sitting at one console, residents sitting at the other one. They have the exact same controls, and the surgeon is seeing exactly at the same time in real time what the resident is seeing. So it's a nice educational tool. And when there's no residents, then there's two of us typically at the consoles, and always, in my opinion, two eyes are better than one, and two sets of eyes are better than one. When you have two surgeons sitting there watching the same surgery, you get to talk through it, and we all go learning at the same time. It's a learning experience the whole time, but I think that our experience so far has shown that we can do this safely, and that's the important thing. Even the thoracic surgeries, two of the surgeons come in, or at least I go in, and if things, thoracic surgery is obviously to be approached with a certain level of respect because of where you're working, and surgery has its complications because it's a system run by human beings, and you're not really supposed to be inside somebody's chest and somebody's belly walking around doing surgery. You're really not supposed to be in there in the end. And so there's a risk when you undertake these procedures. Well, I think we've been able to demonstrate we can do those safely here. So that's what's being said about you out there. Next slide. And here's our statistics. You can see that this actually comes from Intuitive. This was reported to me just yesterday, I believe, and I shared it with on a need to know basis. No. We shared it with all the people that that wanted to be interested in knowing that we got here. This is Intuitive's information, and they keep track of all the surgeries that are going on across the nation. And these are VA hospitals here listed in the bottom. And you can see that number 2 in the nation for year-over-year growth is your own Robert J. Dole. And of course, that'll probably plateau because you're going to run up against, anesthesia access, room access, pre-op, PACU, and that kind of a thing, and actually patient population as well. But this is how we've been able to grow the system here with the people that we have working here. And let me say something else, by the way. Yeah, and this is not a small feat. That this little intermediate hospital in Wichita, Kansas, of all places, was able to not just bring in robotic surgery, bring it in for general surgery. They did it also for thoracic surgery. And it doesn't just stick a surgeon and a robot and a patient in a room. It ain't going to happen. You need anesthesia. You need the peripheral personnel helping you do this. You need the post-op care in the ICU doing this. And we've done it safely. And I'm pretty proud of that. That's not a small thing. That's a big deal. And this kind of backs that up that, we've been able to grow this program and do it safely. Next slide. And in conclusion, I really believe it has revolutionized the field of surgery for us here at Robert J. Dole. It clearly offers superior precision, better patient outcomes, long-term cost benefits, patient satisfaction, and surgeon satisfaction, and also adds to the longevity of your surgeon, who now gets to have better ergonomics to be able to serve our veterans. So it is I think it's a big deal. Most importantly, of course, foremost in our approach is that we're doing this and doing it safely. And so we're working to keep it lean at every turn that we can, and appreciate the support of administration that's allowed us to be able to get to this point. And we intend to grow this program even more, as you may or may not know. But, we're looking at other opportunities to develop relationships with other minimally invasive robotic surgeons. And so just come along for the ride, and the last thing I want to mention is I had a picture of the room, and it didn't make it onto the slide, but, this wouldn't have happened without engineering coming in and wiring the room, EMS helping us to clean it between cases and keep our lag times. So then we report to the National Surgery Office, those numbers are there. Nursing personnel. I couldn't think. Pharmacy has to help us get the ICG dyes to help us, do our laparoscopic gallbladders, for example. I couldn't think of a department that wasn't involved in supporting this system here. So I wanted to say thank you to Robert J. Dole for being able to go out and brag about you when you make these things happen. It's just a beautiful thing to see. And I'll take any questions if you have any.
Thanks, Dr. Vasquez. What we usually do is ask people to put questions in the chat, or we'll get to them at the end of the presentation. So appreciate the presentation on our robotic surgery program. We've seen many things happening with our homeless program over the past year. Kenny Barker, our homeless program supervisor, is here to share information about the program. Kenny, next slide, please.
Thank you so much, Gene. Yes. There I am, Kenny Barker. I've done a lot of work, or our whole team has done a lot of work in the field of homelessness over the last several years. But I kind of wanted to highlight where we've been this last fiscal year and kind of where we're headed moving forward. So, as you can see, we've had some goals every year. The Homeless Program Office sets goals ambitious goals for us to meet as a nation, but then provides each facility with a certain level of focused goals centered around housing our homeless veteran population. In this community, we have 3 very simple but very complex goals. The first one being permanent housing. We can't address homelessness without providing permanent housing. So we had a goal of housing 136 veterans in our community for the fiscal year 24. That second goal is prevention of return to homelessness. We want to make sure that when we find housing, that we are maintaining that housing and ensuring that the veterans who we're not going backwards. And so nationally, the goal is for us to have no more than 5%. I will tell you, as I worked in the community before outside of the VA, the goal for the community, HUD sets a standard of no less than 15% return to homelessness. So our veteran population, those who have served, they deserve better. So we set a goal of no more than 5% returning to homelessness. And then that last goal is as you've seen most likely in the news, and just highlighting some challenges that our veteran population and our population at large faces, is lack of shelter space, and the challenges with getting access to services and care while in an unsheltered setting. So this is an additional goal that was added the last 2 years of engaging those who are unsheltered. And so our goal is to engage no less than 140 individual veterans who may not have a place to stay and are unsheltered for the night. So next slide. How do we go about doing this? Well, I purposely put this one team approach program to pathways, because it just kind of highlights the complexity of services and what you can imagine if you're homeless on the streets or in shelter, what you're faced with and the challenges of navigating a complex system. And so it's really important for us to recognize those who are in those vulnerable states, that they need that level of support. And so the Dole VA has set some priorities of the last year to help us reach and obtain those goals that we set forth for ourselves and that the nation has set forth for us. So first of them being staffing. We ensured that we kept our staff at a rate where we can meet the needs of our veterans. And so just 2 years ago, we had a 75% turnover rate in the homeless program alone, which was top 5% of the nation in our facility. So since then, we've focused on staffing, and I'm happy to say we're over 90% staffed and homeless, and have been so in the last 2 years. So we can't do what we need to do for our homeless veterans without having staff. One big focus has been that community outreach component, and so community outreach is also a major piece, and we can't do outreach just with the VA. We have to bring in the whole community. Case conferencing, I'll talk more about that at the end, but that's a huge best practice that we've implemented for our homeless veterans. And then last is that support services. We've implemented some new innovative ways to meet the needs of our homeless veteran populations, where we're collaborating not just with those programs within the VA, but those without. I will say lastly, before we switch to the next slide, the VA itself has 7 total programs within the homeless program that help leverage this resources and support services for veterans. And so we have a lot going on and a lot of support for veterans facing homelessness. So next slide. And here we are. This is where we're here to celebrate the gains and that we've made so far this year. In fiscal year 24, we ended the year housing 158 veterans into permanent housing. That's a huge accomplishment for not just for our facility, but for the veterans, each one of those veterans that now have a place to call home. And so it's a great tip of in our hat, but just really an awesome thing for us to point to as things that we've done for our veterans. So that prevention of return to homelessness, that's recidivism. So that 2.5% of veterans returned to homelessness. Sad that we had to have one of them return, but I will happy to say that all 4 of those are on a pathway to housing, and 2 of them have returned to housing within that year. So we've been able to keep that number low. And then lastly, the engagement of unsheltered veterans. We outreached 122 street homeless veterans. That's with 2 staff doing the lion's share of that work. So proud to say that we've done made a huge improvement from previous years where we didn't quite reach that goal, but we're missing data from September. So as the lag of data we deal with at the VA, it sometimes happens. I anticipate that we will have reached our goal of 140 veterans by when those numbers do come out. So another just good tip of the cap, and well done for our staff here at the VA. So next slide. We throw some numbers out the VA and I know that we can kind of get washed over with the numbers and miss out on the mission. And so I really wanted to hone in on a quick story, if you will. Just let me kind of share one of the really highlights of our year. We had a veteran that we outreached during street outreach, one of our community-wide outreaches. This veteran, he was an Air Force veteran. He served 2 deployments and was widowed. And so he'd been homeless for the last 2 years, off and on, prior to finally engaging services with the VA. He was outreached by our local hot team. The WPD has a specific task force for those who are reaching out to homelessness, and United Way and the City of Wichita all work together with VA staff to leverage and deploy our team to go meet with this veteran in the community. He had a whole host of comorbid issues and challenges between health and physical health, mental health, but his specific case was brought to case conferencing, where we meet with 16 different programs, 8 different agencies, and over 40 different providers to meet weekly to work through the veterans who are homeless in our community and make sure we're prioritizing their needs. And so this veteran was brought up during case conferencing. And I'll tell you, it was a sight to see, because it wasn't just the VA, but it was 4 different agencies raising their hand saying, yes, I got to meet with this veteran and I want to help. How can we support him getting into housing? Within a 2-week time frame, which we just don't see very often, this veteran and his companion, he had a dog with him, were in housing, which is kind of a feat in and of itself. And so not only did we didn't stop there just with housing, but we wrapped services around him, including getting him to the medical care he needed and the mental health basic needs that he so sorely deserves. There at the bottom, our director Michael Payne has said before that we have a team of homeless providers that ensure that homelessness is rare, brief, and non-recurring. We have some of the best homeless service providers that the VA has to offer. So happy to answer any questions there at the end, but please just know that your VA homeless team is doing everything we can to support those who are on the streets and in our shelters. Thanks a lot, Gene.
You bet. Thank you, Kenny, and great job to your team. It's a great program, and you guys are doing outstanding work. So most of you know that our My Healthy Vet program, you know of it, but there are some changes coming soon that we want you all to know about. So Jesse Colmy, our telehealth coordinator, is here this morning to tell us of those changes and how you all can stay ahead of the curve. Jesse?
Thanks a lot, Gene. So I am Jesse Colmy, like Gene mentioned. I'm the telehealth coordinator here at the Robert J. Dole. I'd like to discuss some updates with the My Healthy Vet platform. As many of you already might be aware, the My Healthy Vet site has now been integrated into va.gov. With that, as of February 1st of next year, the username and password that are used to log in will no longer be in effect. There will be 2 sign-on options available, which are going to be login.gov and id.me. We're strongly encouraging all veterans to create an account with one of these credentialing options so that come next February, there'll be no delay in accessing any of the needed functions of the My Healthy Vet website. If anyone's having any difficulties in creating either one of these accounts, please feel free to contact our office or stop by the My Healthy Vet office. And we'll be sure to get you taken care of. Next slide, please. Next, I'd like to talk about some communication resources. And I'd like to start by mentioning that My Healthy Vet and secure messaging should be used to communicate with your healthcare teams for non-emergent communications only. Healthcare staff have up to 72 hours to respond via secure messages. Though in the event of an urgent or emergent communication need, we have some resources available. First one listed is to connect with a VA Health Connect triage nurse, available 24 hours a day, 7 days a week. Simply call 833-381-1943 and choose option 3. Another great option is to use the VA Health Chat app, which allows you to connect wherever you are with emergency care clinicians. Next slide, please. And last but definitely not least is the Veterans Crisis Line, also available 24/7. Simply dial 988 and press 1 to chat live, or text 838-255 to connect with a qualified responder. The call is free and confidential, and responders can connect you with additional resources to aid in your situation. Next slide. And here on the screen, we just have some resources available. There is a direct line to the My Healthy Vet office in the event that if anyone is having any struggles trying to get that login.gov or id.me account to create, please give us a call, stop by the office. There's also some telehealth resources there. And I will remain on the line if anybody has any questions, but I believe that's my last slide. Thanks, Gene.
Thank you, Jesse. Appreciate the information. Well, it's that time of year again. This morning we all woke up. It was 30 degrees outside, and Pamela Goebel-Roberts, our Health Promotion Disease Prevention Coordinator, is here to let you know about our 2024 respiratory virus vaccination programs. Pamela? Pamela, if you're talking, you're muted. Pamela, your mic is on, but it's not picking you up.
Can you hear me now? Because
Yes, we
took
can.
Okay, I don't know. There must be something wrong with my headset. So
You're good.
Hopefully you can hear me okay without it. So sorry about that. Like Jean said, I'm Pam Goebel-Roberts. I'm the Health Promotion Disease Prevention Program Manager here at the Dole VA. And I did want to get some information because it's vaccination season for some of those fall and winter respiratory viruses that we tend to see. And we do get a lot of questions on how people can get vaccinated and what are some of the recommendations for vaccination. So the three main respiratory viruses that we're seeing seasonally are the influenza virus, COVID-19, and RSV. And the influenza and COVID-19 vaccinations are recommended for all adults unless you've had a reaction to one of those vaccines before. It's recommended that you get those. And it's the COVID-19 came out with the vaccine that has the new variants in it. So the new guidance and vaccine started in August. So if you were vaccinated in the summer before that, a new vaccine has come out since then. So if you haven't gotten that vaccine since the end of August, it's recommended that you get another that has the more recent variants in the COVID-19 strains in it. And then influenza, of course, is updated every year to what is predicted to be the viruses that will be going around and causing infections. So the Dole VA does have both influenza and COVID-19 vaccines available. We do also have the high dose flu vaccine, which is recommended for those patients that are 65 and over. And we are having a walk-in vaccine clinic at our main campus. It started September 17th and runs through November the 8th. And it is in building 29 on the ground floor. So you'd come in through the primary care entrance, and it runs from 8 o'clock in the morning to 3 in the afternoon. And we do have COVID-19 vaccines available, as well as both the regular dose and high dose flu vaccines. So you can stop in during that time if you need both of those or one or the other. We will be happy to give that to you. And you can get both the flu and the COVID-19 vaccine in the same visit if you wish to. If you are serviced by a CBOC, they do have the vaccines available, but it's recommended that you call first, and that way they make sure that they have what they need in stock. So, but you can get those get vaccines there as well. And then if you have an appointment coming up, we do have both the COVID and the flu vaccines in primary care if you have a primary care visit coming up. And specialty care and mental health, they have the flu vaccine. So if you have appointments there, you can get those vaccines at the appointment as well. And then I did want to mention the RSV recommendations because I do get quite a few questions about that. The recommendations were updated for the RSV vaccine. It is recommended that people over 75 years and up get a single dose of that vaccine. And if a person is 60 to 74, it's recommended if you have risk factors such as a susceptibility to lung disease like COPD or asthma, as well as if you have a compromised immune system. So if you're 60 to 74, I'd talk to your primary care provider about if they would recommend you getting that vaccine. And 75 and up, it is recommended that you get that. If you got the RSV vaccine last year, they do not recommend getting another one this year. So you're good at least for this year. And you can request those vaccines from the primary care providers. We don't have that at the walk-in clinics. So if anybody has any questions about those vaccines, yeah, I'm happy to answer those.
Thanks, Pam. Appreciate that.
Yep.
Just an FYI for those who are outside the facility, we do have those flu clinic dates and times listed on the Dole VA website under events. So you can check out times that those would be available outside of your primary care offices. So thanks again, Pam. As everyone knows, the Dole VA is always making changes to improve the way in which we deliver care. Physical building changes are ongoing, and Nick Howard, our Chief of Capital Projects, is here this morning to discuss what's happening now and in the future. Nick?
Thank you, Gene. Next slide, please. Within the VA, we have 3 avenues for construction. First would be what's titled as a major construction event. A lot of the times that's a brand new hospital. So as you can imagine, those don't happen very often. Here at Robert J. Dole, we really have utilized the other 2 avenues to renovate, improve space, and increase technology and maintain our facility. The first one is our minor construction, and it's basically defined as adding new square footage or new space. And then we have a non-recurring maintenance definition, and that's the renovation of existing space. A lot of that's related to infrastructure. Within our minor construction program, we have 6 active projects, about $80 million planned over the next few years. And then in our non-recurring maintenance program, we have about 28 active projects and about 155 million planned. Next slide, please. The first group of projects I'm going to discuss is our minor program. These are projects that are active. There's numerous other program projects that are going on within the program, kind of in the background in various stages, but these are the ones that are actively being worked. The first project on the list is our Building 60 CLC renovation. It also adds new square footage. We are hoping to have that awarded before the end of the calendar year. The next project is our endoscopy project. It actually adds 3 floors to our surgery building, 34. It'll house IT space, biomed space, and endoscopy suites. And then we have a number of other projects here. The next one would be that's under construction would be our infill project, Building 26. That's just started in construction, and it will be adding improvements to our canteen and building new space for dental clinics and our police office, as well as renovating our specialty care services. There'll be a couple phases to that project, and we are planning to have that completed by summer of 26. The Building 3, Building 59 projects that are on the list, those are currently in design and will be wrapping up over the next year or so, and then we'll be able to move into the construction phase of those projects. And then our Renovate Med Surg project, we've had to go through some modifications and redesign to fix some issues with that project, and we hope to have that completed in about 6 months. Next slide, please. Our non-recurring maintenance projects, as you can see, the list is quite long. The top of the list is our boiler plant project. It'll be completed over the next few months, hopefully. We'll be completely finished by early next calendar year, 25. the building is complete, and we're basically starting through the commissioning and startup phases of the new equipment within the building. But our building 4 renovation is underway as well. That's been a long ongoing project, and will be finishing that early next year as well. And then we have a couple projects related to our medical records programs. These 2 projects are related to infrastructure and training. We have partnered with Cerner to utilize the medical records program that complements the Department of Defense as well. So it'll solve a lot of the medical records issues that we've had over the years. And then as you can see through the rest of the list, there's a lot going on that is currently working through design. And as always, we're bringing new projects through the design process as we continue to improve the facilities here and develop new technologies and infrastructure for the veterans. And that is all I have, Gene. Thank you.
You bet. Thanks, Nick. It is very busy around here all the time with the construction guys, so great job. Hopefully most of you know about the PACT Act and its benefits. Jeff Herndon, Dole VA's Public Affairs Officer, is here to tell you not only about that program, but about the successes we're seeing in terms of enrollments across the VA and here at the Dole VA. Jeff?
Hey, good morning, everybody. Thank you for joining us. I know we're a little behind, so I'm going to bounce right to the important slides. So Tamara, could you go forward 2 slides? One more. Yep, right there. Okay, back up 1. All right, so just to remind everybody, there were some changes at the beginning of this year. Originally, the PACT Act eligibility for healthcare was supposed to be phased in. VA did away with that. So there were 3 new cohorts of veterans that became immediately eligible for healthcare as of March 5 of this year. Those 3 cohorts are veterans who participated in a toxic exposure risk activity, and essentially Gulf War veterans and post 9/11 veterans. So they are immediately eligible for healthcare. Tamara, go forward 3 slides to the one that starts Vietnam era. Right there. Thank you. So quick reminder, as of the implementation of the PACT Act of August 10, 2022, all Vietnam era veterans that served in these locations during these time periods were immediately eligible for health care. So if you know a Vietnam veteran, if they're a member of your family, a friend, a colleague, you need to be encouraging them to enroll for VA health care right now. Next slide, please. All right, here's the good stuff. In the first year of the PACT Act, we enrolled over 330,000 veterans nationwide for VA healthcare, and about 114,000 of those were directly related to the PACT Act. And in that first year, we completed over 4 million toxic exposure screenings. In the following year, and these are cumulative numbers now, since the law passed in August of 2022, 739,421 new enrollees nationwide. In the previous 2 years, that was 553,000. So about 275,000 a year before the PACT Act, about 370,000 per year after the PACT Act. Phenomenal increase. And then as you can see, over the course of the next year, we did another 1.5 million toxic exposure screenings. All right, this is great nationwide. Let's talk about here in Kansas. Next slide, please. So for the fiscal year that just ended, September 30th, we hosted or participated in 134 outreach events. We cannot get veterans enrolled in healthcare if we're not out there taking the message to them. And so our outreach coordinator, Tamara Thomas, our eligibility and enrollment team, and everybody else who participates in outreach has been a critical part of this. You can see the number of events that we participated in that we sponsored ourselves. The result, last year, we enrolled 1,316 veterans in VA healthcare here in the Dole VA system. That number continues to change a little bit over the next couple of months, but that's pretty much where we're at. Last year, FY23, that number was 1,289. So we've put about 2,600 veterans into our healthcare system over the last 2 years. The previous 3 years, we were averaging about 790 per year. And so that's a phenomenal increase for us. And then also over the last 2 years, we've completed nearly 25,000 toxic exposure screenings. We've only got about 30,000 veterans enrolled in our healthcare system at the Dole VA. And so we're almost there. We've got over 80% of them completed. That concludes the points I wanted to make today. Thank you everybody for your hard work on outreach. If you know a Vietnam veteran, a post 9/11 veteran, if you know a veteran who is not enrolled for VA healthcare, you need to encourage them to apply. Thanks. Have a great day.
Thanks, Jeff. This brings us to the question and answer portion of the program. I've been watching the chat, and I don't believe that we've had any questions, just a couple of comments posted in there. So if there is someone that would like to ask a question, feel free to unmute yourself and ask. Not hearing any. I think we are done for today. So thank you for joining us today. We look forward to seeing you at our next Veterans Town Hall. Thank you.